Those of you who I haven't met, I'm Bernie Simon. I'm the Deputy Secretary of Developmental and Disability Administration. And with me is John Davis Gross. John was our contractor. Okay. So, many of you know, but we'll just do a little background. In 2014, the legislature passed legislation mandating that DDA conduct a cost-driven rate study. So when we did the RFP and John responded and was the successful company, the issue was what's cost-driven and what does it look like? And you can hire an accountant and say, well, give me some rents, right? But that doesn't engage what does it really cost you to provide support and services. And so I know that there have been times when I've been out in the community visiting with some providers, and I was at one part of the state, and they said, do you want to see our home that provides respite services? And I said, yes. And I said, what does it cost you per day? And he said, $250. And I said, what do we pay you? He said, not $250. So obviously, you know, there's a cost, which is why you need to get a good study done, good interaction, back and forth, and John will explain that. Obviously, the cost of transportation is extremely important. And John will talk about the 7 to 9% versus the 49% later on in the presentation, and that the legislature also told us to develop a better payment methodology. So some of you know that we've been engaged and are going to use the long-term supports and services, LTSS platform that Medicaid uses. We've been working with, we're a task order below them, so we're part of the overall Medicaid, because they've got like 5 or 6 areas going. We're a task order. We are moving forward with that. We've been working with a contractor with them in Columbia. FDI is the contractor, and we're doing the design. And you'll see as this rolls out and it's implemented in July of 2019. So 2018, we have the new waiver coming in, new waiver definitions. We will be implementing some of these rates. We're going to have to figure out how we're going to invoice, and we'll do trainings and all that stuff. But 100% implementation should be July of 2019, which is fiscal year 20. And if you look at your chart that you have in there, you will see that and John will go over this about 2018 versus 20, and how there was a forecast for what that actual cost was going to be, and then what the delta is between fiscal year 20 and fiscal year 18, and what that means for general revenue, as well as general revenue and federal drawdown and match. So we're here because we said we'll roll out the final report. We've shared it with quite a few people. We've shared it with EBM. We've been with some of the key stakeholders who you engage with in the Senate and the House, and share that with them. And now we'll do the town hall meetings, and then John will be working in the future with each individual agency and what does that fiscal impact mean. So is there any questions for me before I get to the back of the room and let John describe the whole process and where we are? Seeing none? Good. Thank you.
Stay away from that thing. Can y'all hear me okay, everybody? Thank you all for being here. Appreciate you taking the time to come out. We've got 2 hours tonight, and what I'd like to do is take the first 30 minutes and get through the slides. That'll give us an hour and a half to field discussion and talk about questions, and hopefully by the time you leave tonight, hopefully you'll know what you came here to find out. There's a lot of information to cover. I want to start by expanding a little bit of what Bernie said, that our company, we're a small company. We're only about 6 or 7 consultants, and we've worked I've been a Medicaid consultant about 17 years, and I've worked in Medicaid for 27 years. But we are a small company. Most people have never heard of us. But we prefer to work with providers and with family members and advocates when we do what we do. I have an accounting background, but I also have been a mental health social worker in the past and am a mental health practitioner in volunteer work. Mary has a social work background. We're actually more social workers than we are accountants, but we do have an account. I sat for the exam back in '97. Our philosophy is you can't do good rates unless you talk to the people who use the services and the people who provide them. Y'all have probably even heard me say before, anyone with a calculator can create rates, but you can't implement rates without building consensus. So when they solicited the project, that's what they wanted. So when we saw the solicitation, Mary and I looked at each other and said, it's like they wrote this for us, because they're asking the bidder to do things exactly the way we like to do them. And there was a lot of input. And there is going to be continued input. I've got 2 slides tonight that will tell you about what's going to happen now. And there's a lot that's going to happen. We had 2 groups that we put together, the service quality group and the technical work group. Mary led the service quality group and I led the technical work group. When we get to question and answers, if you have questions about the quality work group, Mary can answer them probably better than I can. The technical work group that I worked closely with worked very hard. In fact, Chris is here. He was one of the members of the group. They contributed an awful lot. We didn't always agree. I didn't always agree with members of the technical work group. It was a back and forth thing. But the 49% that is now in the rate system for transportation was really a response to Chris and one of the other members. I was going to put 7% in there. And they basically said, that's never going to work. So we went back to the drawing board. We got a couple of them together and they said, we need you to look at all of this stuff. So we looked at about 3 different approaches to it and came up with a basis for 49%. I didn't come up with that. The tech group did. So this is the membership. You've got this in your copy of slides, so I'm not going to read to you here. By the way, just went backwards there. No, this is a different method. So the presentation slides that you're seeing right now are the same slides that we presented to the legislators that we spoke to and to the governor's office. So you're seeing the same thing they saw. But there's some slides in here that you're going to see that they didn't see because we're giving you some more detail. For those of you that are not familiar, how many of y'all in the room have never seen anything about the BRIC method? You've never heard of it? You're not familiar with it at all? Some of you. Okay, let me give you just a real basic Reader's Digest version of the system and why it's different. It started back in the mid-90s when I was a CFO for Arizona, and we had a piece of legislation that mandated that we create a standard fee system. I met with a bunch of case managers. Mary was there. Mary and I have worked together since the early 90s. And we wanted to have the standard fee system about the services. So all of the components, one of the aspects of the system is that all of the components tell you something about service standards. Accounting firms that do rates, you'll see a lot of them use a component that's just referred to as capital. Well, capital doesn't tell you anything about the service. So all the components that we have here are there because they tell us something about the standards of care. The only exception is G&A. But you've got to have G&A. Every business has G&A. And all of the others are service related. Now you'll notice that one of them is transportation. That's because we started isolating transportation as a unique component about 3 or 4 years ago. I think we isolated it first, I think, in Oregon, but we isolated it also in New York and New Jersey. But up there is also one that's training. Yeah, can y'all see that? You can see it in your list. That came from the service quality group. There's 2 things that I think deserve to be mentioned. There's a lot of things, but I really want to point this out. Mary and I like to try to find anything that we can that will relate a quality-related initiative to a rate system. We're always looking for things that we can point to that are there because they have an influence on the quality of care or quality of the service that we can put into the rate system in a way that it can be seen and observed. And we don't get that opportunity very often. You know, when you put people in a room and start talking about quality of life issues, you hear a lot of interesting stuff, but most of it is very hard to quantify. You know, someone says, I'd like to have a girlfriend, or I'd like to have a boyfriend. How do you put that in a rate system? But they were saying, we heard from the quality work group that if you were to do something that could really give the providers enough resources to really train the staff, that would have a direct correlation to the quality of service. So we said, okay, let's look at that. And we split it out as a different component. So training as a separate component is this is the first state that it shows up that way. Now, I also want to tip my hat to the state folks, because just because we want to do something doesn't mean that our client always allows us to do it. And there's a couple of instances, very noteworthy instances, that I think are very, very important, very forward-thinking things that we didn't do. They came from the state. But when we talked about, we think that quality can be affected by training, we'd like to look at that and make sure we've got an adequate amount in there. And they said, yes, go for it. I didn't expect them to do that, quite honestly. So anyway, there was input, and there continues to be input. At the end of the night, if y'all have questions about those components, just let me know and I'll explain them. Let's see, what's the next one? CMS Federal has very specific principles that they require are part of standard fee development. There are some guiding principles that bean counters like myself have to make sure that we regard when we're putting together standard fee structures. One of them is that true costs have to be expressed somewhere. Y'all know as providers, you never saw a request from us to fill out a survey. Did you? Did anyone get a survey to fill out for us? I'm curious to know, because we didn't send it. If somebody sent you a survey, it didn't come from us. We only work from general ledgers. We ask the providers to just download their expenditure categories to a spreadsheet and send them to us so that we can do the analysis. So we have some reason to feel secure that the analysis is done consistently from one provider to the next. Then what we do is we schedule phone calls, and we call up providers and ask them questions about the ledger, make sure we understand it. Like, if you were one of those folks that I talked to about the ledgers, you'll probably remember if I called you, if you have a line in your general ledger that's depreciation, I would ask you, what are you depreciating? If it's a big copy machine, that's G&A. If it's a Hoyer lift, that's program support. So there are some categories of general ledgers that we really can't know what it is, so we have to talk to the providers. So this slide here is an example of what we do with the ledger. The little letters, the code, DE, those are the codes that relate to the component of the rate system. The D is direct support staff, direct support professional. E is employment related. G is general and administrative. The same ones that you saw on the previous slide. We add them up, we divide them by the dollars that are present in the direct support line, and we come up with a percentage. So the first thing I need you to be sure you know is when you see the percentages in our final report and in the rate sheets, they don't add up to 100%. They're not going to, because they're not a percent of the total. They're a percent of the direct support wage. Is that clear? I don't want to go any further till I make sure that's clear. That is an easy detail to look past, but it's very significant It's one of the characteristics of the BRIC method that is unique. There's no other component-driven rate system I know of that is structured that way. Can you imagine why we structured it that way? Can any of you guess? You didn't think I got to ask you questions, did you? Can you all guess why it is that way? So that if the legislature or the governor's office decides that they want to increase the direct support wage, which they often do, all of the other components will increase as well. The system will sort of automatically rebalance. It's designed for that. Some people tell me, you made a mistake here. It's no mistake. It's part of the design. But it is a little bit confusing. So that's how we do the ledgers. This slide is simple to look at, but it's actually pretty complicated. It's a very high overview of the process of creating and implementing a standard fee structure. There's really two processes that are going on parallel, and one of them is going to continue. One of them is basically finished, but for some tweaking, and the other one is going to continue, but it's going to continue with much more contact between myself and two of our associates and the provider community at large. The amount of contact that we're going to have with providers is about to double or triple. It's not over. In a sense, it's almost just beginning. But on the left, you have the general ledgers, which tell us the components, which give us the calculations. Then we go and we get the direct support wage, and we rebuild the whole turkey sheet based on the direct support wage. That's the structure of the rate system. But if you've ever attended any of our other presentations, you've probably heard me say that new rates don't mean new money. Just by doing rates doesn't mean that we automatically increase the budget. We don't have the authority to bind the state's general fund. No one has that authority but the governor. But one of our founding principles, or one of our philosophies, and if you guys want to know more about it, you can go to our website. Right now it's being completely redone, but I think the old one is still up, and it's jvga.com. When our clients, our state governments, ask us to do standard fees, they ask us to create a fair and equitable rate system. That's one of the principles of Medicaid Federal. The rate systems have to be supportable as fair and equitable. They don't necessarily ask us to create a budget neutral rate system. They ask us what is a fair representation of cost. And we always take the position that that is a question that we will answer. Is it budget neutral? Is a separate question. So what we have to do is we have to figure out how much is it going to cost? Because we make no guarantee that it's budget neutral. And in fact, I've personally been criticized quite a bit by some of the other consulting firms by saying that I've been told you're irresponsible. You're putting the government in a position to have a rate system that you can't guarantee they can afford. And that's happened publicly. And I said, well, that's not what they asked me for. They asked me for fair and equitable. So while the rates are being developed, we're trying to measure the impact that the system will have. The only way we can do that is by talking to providers about what we refer to as utilization. The whole system is based on the direct support professional hour, whatever service it is. We need to know how many hours there are. Because the BRIC that is referred to when we say BRIC method is the hour of direct support professional time. It's that hour. It's just fully loaded. It's got everything in it. It's got program support, ERE, G&A, transportation, training. It's all in there. It's like the spaghetti sauce, but it's only 1 hour. So we know how much it's going to cost by asking you guys, how many hours are you providing? Something else I was going to say, and I can't remember. Oh, like, for example, if you're operating a congregate residential setting, and you're you're one of the people who live in your homes is John. Well, if John needs 10 hours in a 24-hour period, what do? You multiply 10 times the brick, and that's your rate. So the rate system allows for you to have a rate that is one-on-one, 24/7. It's just 24 times the brick. It also allows you to work with ratios like you do with day programs typically, where you have one person doing the service but more than one receiving it. If there's two of them, you can just divide by two. It's all based on that brick. That's the point. So we have to figure out what the system will cost, and then we calculate what we call the funded percentage. You'll see the actual numbers here in a minute. The funded percentage, by the way, is the amount of the system that is currently funded by the budget. So if you see a funded percentage of 90%, that means that the current budget only funds 90% of the system. And those percentages vary. They also change over time. In fact, they're probably already changing. Because what happens is the providers, when they see the rates, they automatically start adapting. Not all of them, but many do. And that changes the funded percentage. Now, what's going to happen here, which you're going to see in a minute, I'm going to spend a little bit of time on this slide because I imagine this is something you're interested in seeing. The last two slides are what we're going to do now, what happens now. And a lot of work that's about to happen, about to start, is further investigating that budget impact by provider agency, by service. So the total price tag for the system right now sits at $74.8 million. Of that, $38 million is general fund. Bear in mind that that price tag includes dollars to increase the direct support wage to the summer of calendar 2018. We use the Bureau of Labor Statistics to get that wage because we didn't want to say that's our opinion. Nobody cares what our opinion is. We need something that we can point to that's objective, so we use it. Calendar 19.
Our implementation is for July of 19.
Okay, I misspoke. Yeah, another year, a little more than a year and a half. We accelerated, the Bureau of Labor Statistics is a great source of wage information. The only problem is it's usually 2 years old. So we accelerated it to the year of implementation using the Medicaid CPI. And that's in the report. Everything that I'm saying to you is in our final report. You can see everything. In fact, if you look at it, once you understand the system pretty well, you can redo the rates. You can do them just like you can trace everything back. So the total price tag right now is $74 million, just under $75 million with $38 million in general fund. That is only core services. That's just the residential, day, supported employment services. No, employment services are not up there for a couple of reasons. And then targeted case management. I'm going to talk a little bit about targeted case management specifically because I see some targeted case management folks in the audience. I'll answer questions about that in a second. This is what I really wanted to make sure that y'all knew about. The budget impact analysis is done in the universal sense, in that we find out what is the state's budget capacity to fund the system we're proposing. Well, we have to do that by provider, because if a provider is going to suffer under the rate system, we want to know it. Now, there's 107 provider agencies that we already know what's going to happen to those agencies. We call that the A list. There's a B and C list. There's 3 different sets of data that we need from the providers to measure the impact. We need a general ledger profile from them. We need those direct support professional hours that I mentioned, and we need to know what were they paid by the state in the past. Because we're going to do what I what I just mentioned doing. We're going to multiply our new rate times your hours and compare it to your past revenue. We've already done that for 107 providers. So we're going to be reaching out to that 107. So please don't call us, because there's only 5 of us. And if Claudia gets overwhelmed, I don't have a backup for Claudia. She's all I've got. But bear in mind, we will be reaching out to you. Now, what we're planning to do is put a calendar up on the state's website that lists time slots for phone calls. We're going to send you all an email saying, here's the data that we have. You'll get one of 2 different kinds, 3 different kinds of emails. Either you're an A-list provider, and we'll send you an email saying, here's what we think is going to happen to you, and it'll be there. You can see it. We got the DSP hours from you, so those should look familiar. Then multiplied by the rate compared to your past revenue, it's either red or black. So we'll be able to say, this is what it looks like for you. We think we need a call. If it doesn't look good, or if it looks too good to believe, which is equally possible, then we'll suggest that you call us, that we have a call with you. If you get a request for a phone call, then you can go to the state's website, get the calendar, and Claudia will have all the times that are available for a call. Send her an email. Our email is always the same, and it's only one email. We only use one email address, and that's a JVGA team, JVGA followed by the word team, like baseball team, @gmail.com. Claudia and Christy will triage those emails. And then she'll put your name, your agency's name, not your personal name, but your agency's name in that time slot. So the next time you see that spreadsheet on the website, you'll see your name in your time slot. And then we'll call you to talk about what it's going to look like for you. If we don't have all 3 of those data pieces, you'll still get an email from us, but we'll say we can't schedule the call yet because we need either your ledger so we can do a profile for it, or we need a DSP hours. We need something from you before we should have a call. Or you'll get one that says we don't have anything from you. In fact, we don't even know who you are. There's a couple of those. But bear in mind that as we move into this process, this next stage of the project, we are probably going to be talking to between 140 and somewhere between 140 and 200 providers. It's going to last about 6 months. We're scheduling, we would like to schedule 5 calls a day, 1 call per hour, and the calls will last about half an hour. Those calls are very fatiguing. By the end of the day, I'm just wiped out. So we don't like to have more than 5 a day. Now, the second 2 weeks of March will be, for 2 weeks, I'll be in Maryland, and we're going to be going to each of the 4 regional offices, either for 2 days or for 3 days. 2 the first week, 2 the second week, and we're going to offer time slots to the providers to come in and talk to us in person. If after our phone call with you, we haven't gotten to the solution, then what we'll do is we'll say, we really need to sit down with you in person. We think you should, bring your computer, bring whatever you've got. Let's sit down and figure out what's going on. Because this is what I was leading up to. There's only a finite number of things that it can do. If you're going to be hurt by the system, there's only a set number of things that it can do. It's either your component percentages from your ledger are out of whack with what's in the rate system for some reason, or it's the wage that you're paying is much higher than what's in the system, and I doubt that's the case. I don't think I'll see any of that. Or it's the utilization. It's something with the utilization. It has to be one of those things. Now, there are some changes to the rate system, and I'm sure some of you have come prepared with questions about the rate system now that you've seen it, because not everybody got what they wanted. You know, I tried to do everything I could to justify increases to the rate system, not just to the states, because they've been willing to look at pretty much anything that's reasonable, but to be able to say to the feds, we exercise due diligence. I can back up everything in here. But not everybody got everything they wanted. There were some people who wanted me to do something that I ended up not recommending. So, but it's all in the report. You should be able to see it all. So let me make sure I got all of this stuff covered. A group is the ones that we've got everything we need. B group is the ones that we've got something but not everything. And C, we don't have anything. I've gone through the rest of those I've already talked about. And then here's the training issues. We're going to be doing, every time we go out to the regional offices in those two-week periods, one of them is the second 2 weeks of March, the other is the second 2 weeks of June. We're going to start with, we're going to have training for the regional staff so that they know how to, they all know how to operate the system, how to talk to providers about it. We'll have meetings with family members and people who use the service to teach them how to use the system and what to expect, what's reasonable for the families to expect from the providers and what's not going to be reasonable under this system. So that the last thing we want to do is pit the families against the providers or pit the providers against the families. So we want everybody to be singing on the same song sheet. And then we'll have meetings where the providers come in. In addition to this training, I don't know when yet, but it'll probably be June or May or June, kind of late into the next phase. I'm planning to do provider workshops and make available a place probably like this where you can come in, and if you want to, I'll help you code your general ledgers so that you can produce internal management reports that mirror the assumptions in the rates. So I'll show you how to put an identifier in your chart of accounts so that you can produce a report that tells you what your ERE percentage is compared to what's in the rate system. That training is not up here. I'm calling those workshops. I do that. I've done that pretty much in every state where I've been. Providers usually like that. That's usually a really good day. And then after that 6 months, we're going to look at where did the rate system go wrong? Where did we miss the mark? What didn't I understand? Or what did I understand incorrectly? And how we fix it. So that's what it looks like. Now we should be wrapped up with the second period, probably early in the fall, next fall, about a year from now. And then, as far as I know, the state has indicated an interest in the second renewal option, which would be another year after that. They may not need that, but I think that's available. So we're going to be here for a while. And the next 6 months, we're going to be talking to people and turning on the lights. So I think that's what I had for the slides. Now, as far as the rest of the time tonight, I'm here to answer your questions. I do have to be careful. If you ask a question that seems like it's specific to your agency, I may say, can you just send that to us in an email, and I'll answer you by email. Because I don't want to get to the situation where I'm answering questions that nobody else hears the answer to. We really want everyone to hear all the questions and all the answers. But if you ask a question about your agency, the rest of the folks don't necessarily have time to hear this. So I'm going to open it up. Kim and I were talking earlier, and I told her about this true story. We did one of these. I did one of these back in the 90s in Arizona, and we expected about 50 to 100 people. 400 people showed up. The fire marshal kicked us out. 400 people streamed out into the parking lot pissed off. Not a good day. Do y'all all have cards? Yeah. I think we have to hand it to someone. Can I read it?
We try to record the questions on the microphone if you want. Or if you want him to jump in.
Yeah, that'd be great.
Either way.
Do you plan to test LTSS claims-based billing prior to July 1st of 2019?
Did y'all hear the question? Yes. The answer is yes. Absolutely, we expect to spend quite a bit of time. We talked about that this afternoon by coincidence. While we were making all the phone calls to the providers, I'm going to start meeting with the LTSS folks to get a handle on how their system is structured, so that I can hopefully foresee any problems we might have. Because we've actually got two different environments. We have the LTSS environment and the MMIS environment, and they each have different issues. But we expect to have a really good level of comfort that we're not going to go up on the rocks with the claims aging by fall, by the end of the summer. And every time I've done a rate system like this, we've done that. We've gone through that process. So it won't be the first time I've done it. I have a pretty good sense of if something is going to look risky, I'll know it pretty quickly. But I won't really know what we're doing until I dig into it. But yeah, the implementation phase, what we were talking about this afternoon, was that the implementation phase has two parts. One of them is measuring and managing the impact on each and every provider. That's half of the implementation stage. The other half is making sure claims pay out. And we look for payouts in 30 days or less for a clean claim, because that's the Medicaid guideline. So long-winded answer to your question, but the answer is yes. Do you want to come up? Can they come up here and speak? Okay. We just want to make sure we get your question recorded.
So in looking at the rate page of your 40 pages there, is it that, am I seeing it that we'll be paid the same for a staff person taking a group of 4 out as well for a staff person taking one person out?
For which service?
Day. It looks like the rate is $33 an hour for one person. It looks like for 4 people it's $8 or something an hour, which times 4 is 33. To me, that says that we would be paid the same for carrying a group of 4 people around as we would for a group of 1.
Well, actually, the day program structure is not quite that simple. It is ratio based, but it's more than one ratio. It's 1 to, didn't we say 1 to 4 and 1 to 1?
Yeah, and it's $33.03 an hour for 1, and it's $8.76 an hour for each for 4, which times 4 is 33.
Yeah.
That makes me think that we're paid the same for running around with a group of 4 as it would be for taking one person around. Is that what that says?
Yes, that is what that says.
And is that going to work, Bernie, with the new stuff we're trying to do with Brooklyn?
Yeah.
How's that sort of, and it's not, Tennessee gets a lot of attention these days for being at the forefront, first transition plan approved and all that. The webinar I saw from the Tennessee people, their day rate doubled to implement closing day programs. It's exactly doubled. I mean, when I cost this out, just that one little piece there, what I'm getting right now for taking 4 people around versus what they're getting with this, it's like 80,000 versus 49,000. They're losing a ton of money.
So and you'd have to go back.
I don't care how that's supposed to work.
One of these slides that we didn't address was unemployment and community development services. You saw the 4 papers of residential, day, personal support, and time vacation management, right? So as people move from some type of day services into the community, we can't forecast because we don't know how many people at what rate and what ratio of the implementation of the community center school. So that's why you see at the bottom of that, like 3 slotted back, that's what that says. So we don't know what it's going to cost, right? We know those 4 areas that it's $74 million in Fed and GR, or $38 million in GR. But as you transition again from day to the new wave of services, CBS, et cetera, your rate should change and it should incentivize you to go to those services and not stay.
Well, this is actually the service I'm talking about. Community day services.
CDS.
The first one on the chart.
Community development services.
Yeah, 33 a day. 1 to 4.
Right.
33 a day, 1 to 1.
Well,
There is a couple of things going on, and I think one of them is what Bernie was referring to. Day used to be a daily rate, now it's an hourly rate. So it's designed to be combined with employment support services. The day is not the only thing that happens in that day. It's designed to be combined with employment-related supports. The other thing that I would mention is that that's actually one of the reasons why we increased the transportation component, was because by shifting from a daily rate for day programs to an hourly rate for day programs, and this is something I was educated by, Chris was the first person to make me aware of this, was that there was a whole segment of time that was billable under the day program day billing, but not available under hourly. So that's why we increased to the 49% for transportation. The other thing that I would mention is that the funded percentage for day program is down around 85%. It's the lowest funded percentage of any of the rates. So if that is going to be a fail, if that structure is going to be a fail, we will discover it in the next 6 months. I don't think it will be. In fact, my concern right now is that the day program rate might be too high, because it's only funded at 85%. So that means 15% is being added to that service budget. That's a lot of money. Day program is probably 30, 40% of the budget. So it could be a fatal flaw, but I don't think so. But that's why, because we jacked up the transportation, so it's a pretty hefty. In fact, you can look at our rate system in several other states. That's the highest brick for day program I've ever created.
Explain a little more to providers about the hourly billing for day program and the concerns that we expressed in the February group about utilization. Right now you're funded for an 8-hour or 6-hour day program, some of us do 8 hours.
Yeah, I know what you're talking about. Are you recording what I said? Because I can repeat his question. Okay. What Chris is alluding to is a discussion, and it's, to be very honest, it was difficult for me to truly appreciate what the tech group was telling me. It took me a while to understand what they were saying, because this is the first time that I've been involved in a rate structure system that goes from daily rates for day programs to hourly. Personally, for what little that's worth, I think it's a good idea to go to hourly, but it's the first time I've ever done it. So there are some things I just have never experienced. What they made me aware of is that some day program providers' day, in the old sense, was predicated on 6 hours. Other providers' day was predicated on 8 hours. So there has to be some kind of a policy decision about how to make that uniform. Now, policy alone probably isn't going to fully address that issue, because distance a lot of times affects that every bit as much as policy. So, so they said, how are you going to deal with that? And I didn't have an answer for how, I didn't come prepared with an answer to that question. I think what we have to do is discover that. Now, here's how we will discover it. When we do the analysis of day programs, those providers that are going to get clobbered under the day program will be having telephone calls with them. So we'll be able to dig into it and figure out what's going on. That will fit into the category that I refer to as a utilization category. It's a utilization issue, not a wage issue necessarily, not a component issue, but it's utilization. So I don't have the answer to that question, but I know how we're going to solve. I know how we're going to get the answer.
I just want providers to start thinking about that, because as long as we need that data to be able to have a legitimate conversation.
Yeah, no, I agree. And the better that data is, the better we can see it.
If you have an 8-hour day program, even a 6-hour day program, you'll be able to start billing data. If I'm wrong, correct me. You'll be able to start billing day program when you pick that individual up for services. Unless you have a magic bus or a magic car, you can't pick everybody up at the same time. So if you're able to bill 8 hours a day, and the first person gets picked up at 7:45, then 8 o'clock, then 8:30, then 9 o'clock. Some of those people you're not going to be able to bill for 8-hour service, day service for. And the compensation that I've seen from some of the providers is that they push their routes out earlier and later. I've got one provider, I looked at their transportation data. Their runs are starting at 5:30 in the morning, picking people up, and they're dropping them off at 5:30 or 6 o'clock at night. And they're getting 8 hours of supports in between, but they're doing so at the expense of the individual having a 12-hour day.
Yeah.
To have a legitimate day, I mean, I don't know about you, but after 8 hours of work, I'm ready to go home, go to sleep.
Yeah.
I can't have that 12-hour window. So to get to a reasonable support for the individual and for the family themselves, because again, if I have a family member, I only get up at 5 o'clock in the morning to get my child or my brother ready for a day program or for a TV outing, whatever the service they're receiving, or expect them home at 6 o'clock at night when they should be eating dinner or getting medication at 5 o'clock. It's going to be a utilization issue.
Yeah.
And the only way to bill is to expand your time frame. So, and you're still going to be able to bill more than 8 hours. So either you get maximized 8 hours of billing and you're eating the expense on the front end and the back end and staffing it overtime, or you're shrinking your revenue. There's no in between. There's no way to solve that issue. And the concern that I expressed to you really is it a utilization issue? You can say it's 85% funded. I think when the rubber meets the road and you get that first round of billing, you're going to see the providers are not able to bill for probably, the estimates that we did, most of the providers are about 15% at dead time.
I absolutely believe the possibility of that.
I mean, as you guys start to look and sit down and have that conversation with John, you're going to need to be aware of when you're picking people up, when you're dropping off, and how that's going to impact what you can and cannot build. Because that's going to be the bottom line for you in a day program.
We will be looking for that. I mean, we'll be actually looking for that. And here's why. You know, like some of you, how many of y'all that I talked to about general ledgers? How many in the room had the general ledger call with me? I figured it'd be about half of you. Remember me saying that we were looking for acuity differences in the program support percentage? We were actively looking for that. We were looking to see, is there evidence that people who have medical issues and psychological issues sometimes, is there evidence that the cost of providing care for them is noticeably different, that we can defend to CMS? That's why we had those calls most of the time. It wasn't just about depreciation. This is a very similar situation. The fact that we're going from a daily billable unit to an hourly billable unit solves a lot of problems. It solves a lot of issues. It's a difficult transition to make, but it's worth it. But it creates an opportunity for us to say to CMS, for me to say to CMS, because my responsibility is primarily to the state, but I have a responsibility to the feds too. I can't give the state something that the feds are going to say no to. But this gives me an opportunity to say to the regional CMS folks, this is an unknown. We're transitioning from a utilization pattern that's based on a day to a utilization pattern that's based on an hour. If we're lucky, we'll hit it right on the beam, but we don't know until we talk to y'all. So when you have those calls about day programs, I'm going to be telling you, just like I did with the acuity thing, I'm looking for the impact it's going to have on you going to an hourly program. So you'll know what I mean when I say that. Because I already know whether it's a component percentage, because I already have your components. You will too. Now, I
have an answer about whether we'll be able to bill 6 or 8 hours. I think that would be maybe a party question.
yeah, I haven't had any more discussions about that.
Is there a decision to made on the cap of number of hours per day? By the way, the conversation about 250 billable days a year. I know they call calls that maybe we do appreciate that. So a little bit down there. Thank you.
Y'all need to probably know that as of this moment, I don't know what your wages are. I don't know what wage you're paying. I've never asked for it. I've only ever asked for the total dollar amount.
We sent them a wage survey over here.
Yeah, but that wage survey includes supervision as though it were direct, which is fine. It's just not what we do. Our direct support is unique. It's not a supervisor, but it may be some of the supervisor time. A house manager usually splits their time, as you know, probably better than I do. But it's a little bit different.
Today on the website, and we do have the hours in each of the definitions. So you'll see that we do have hours in there.
Hey, thank you.
The other thing that I wanted to take a minute and recognize the state on, and I did this in the final report too, we included a tiered structure for the direct support professional wages. We used the New York blend because it's the only data there is at this point. The first time we've ever done that, we did that at Bernie's request. I think that's very forward thinking. I would call your attention to it if you missed it in the final report. A great feature. I've said before, you don't get what you can't measure. And if we may not have those DSP tiers perfect right now because there's no data other than New York, but because the rate system has it in the structure, you'll be able to measure it going forward. Do y'all know what that is? What the DSP tier structure is? You know what I'm talking about? It's a incremental increase to the direct support wage based on their advancement in their career path. Yes, sir.
I was going to ask a question and kind of flip gears from the day to the residential and the personal supports and things like that. The rates for day are about 133% of what the rates are for residential and personal supports. What is the rationale for that?
Did y'all hear that? The rates for day are considerably higher than the rates for residential. It's transportation. It's the transportation issue related to the shift from a day to an hour. That is what did that. It was going from 7% to 49%. Because of that issue, that they're shifting from a day to the hour, that their ability to bill for chunks of time is going to go away. Now, whether 49% is too high or too low, we really don't know.
You said earlier that the transportation, I mean, the time the day program began when the person was on the bus.
Yeah, and that's what Chris's point is. Chris is saying that you say right now that it's an 85% funded percentage, but it may not be. Because once you adjust for that 85% may go up to 95%, being that they're not going to be able to bill because there's only so many hours in the day. So that's what we really need to discover. Right now we're saying it looks really high. It does. I mean, I just said a minute ago, it's the highest I've ever created. But it may not be high enough, depending on what the impact of that transportation is.
It looks like the rates, especially on the personal support side, are actually greatly reduced from what they are today.
I expected the personal supports issue to come up. And in fact, I'm surprised it wasn't the first issue that came up. There's so many things to talk about in that regard. personal supports in Maryland right now is migrating in a direction, and the way we captured this change is by treating personal supports, or what you historically we refer to as independent habilitation. In my simple brain, I only think of habilitation as residential and independent. And what makes one and the other is whether or not the person is in control of the environment. If the person who's using the service is in control of the environment, it's independent. If a provider's in control of the environment, it's residential habilitation, the old classic group home model. Well, Maryland is moving towards a hybrid, which is unlicensed congregate. It's still independent habilitation, but more than one person is resident in the environment. But the purely hourly, one-on-one, classical independent habilitation, that brick typically is lower than a congregate setting residential brick because the program support costs are lower, usually related to the person's independence. And that was borne out in the general ledgers.
An hour from residential, an hour for person support roughly
Very close. And the reason we didn't make it even lower, because in other states I've made it even lower, is that typically the G&A percentage is not the same. But I talked with this state about this, and we decided collectively to keep that G&A percentage the same for independent as well as congregate licensed, because we don't want to put a disincentive in there for congregate residential providers to move to unlicensed. That's what we want to do. But historically, we don't even put G&A at all in independent habilitation. We left it in Maryland because we don't want to discourage that. I think that's hopeful as a solution to the room and board issue, if we can work it out. If we can just navigate to it, I think we can solve a lot of problems that way. Personally, my own opinion, but again, what little it's worth.
Can you discuss a little bit? You just mentioned the room and board, the housing issue, because the CMS rules that you have to follow the set rate clearly affected the residential rate because we've left that whole component out. And I mean, I've sat meetings, I'm still kind of fuzzy on it. I think the buyers that haven't been there kind of elaborate, at least let them know where we are, and then the equivalency theory that you were at least initially discussing, if there's any progress at all on that, or where the whole general where we're headed with that piece of the component.
Yeah, let me capture that question by saying I'll talk about room and board, because there's a lot to talk about on that. What you refer to as a theory is what the analysis ended up showing. But what Chris is talking about is probably the most difficult problem to solve in long-term care services in the developmental disability world today. Transportation, room and board, neck and neck. And as you all know, that any of y'all that are congregate residential providers, you know that the SSI benefit doesn't come close to compensating for room and board. Try doing rates in Washington, D.C. if you want to see a horror story between SSI benefits and ward rental rates. The problem, the genesis of the problem, is that Medicaid won't let us compensate for room and board in a Medicaid-covered residential habilitation rate. That's a federal prohibition. And that dates all the way back to the misty past when waivers came about. Do you all know what's being waived? We all talk about waivers. Do you know what's being waived? The section of the Social Security Act that requires that they're in an institution. That's what's being waived. In the 1915 waivers, it's section 1915. In the 1115, it's 1115. But it's about being in an institution. So when Medicaid agreed to do that, they said, we'll allow you to get Medicaid coverage outside of an institution, but only as long as two things are there. One, we're not paying for room and board, and they have to be cheaper than they would be in an institution. Otherwise, the neutrality demonstration, you already know about that. Now, what Medicaid thinks of as room and board is the SSI benefit. Because if you look at the Social Security Act, the SSI benefit is a room and board benefit. So on the one hand, Medicaid says, we define what room and board is because that's the SSI benefit, and you can't put room and board in your rate. Meanwhile, their SSI benefit doesn't cover room and board. So the problem that Medicaid is in is they have to listen to us say, you shouldn't stop us from putting something in the rate for room and board because your SSI benefit isn't enough. But they can't increase their SSI benefit. They're not willing to increase their SSI benefit. So there's a huge crack that providers are falling in. Now, what we explored when we were working with the tech group, and I did all of this analysis, this wasn't the others, I did this myself. There was some belief that at a point in time, 20 or 30 years ago, there was something in the rates that covered for room and board back in the 80s. And there may have been, but it has eroded over the years, and it's not there anymore. So I searched for it, I looked for it so that I could hopefully come up with some basis for making an equation between what the existing rates are and what the new rates would be if they had some sort of accommodation for room and board, but I can't justify that. And the way that I found that, the way that I discovered that was by taking the rates that are in existence today that are linked to the matrix and comparing them to our rate for the same number of hours. And they're within 0.5%. And ours don't have room and board in them. So the analysis showed that the room and board is not in your current rates, even though it might have been 25 years ago. So we then talked about the issue of, well, how about increasing the amount that providers can get of the SSI benefit? You know, my opinion on whether you do that or not is no more valuable than anyone else's. I can tell you that Maryland does collect on the low side. I mean, Arizona, Idaho collects quite a bit more of the SSI to offset the room and board cost than Maryland does. But there's all kinds of things that are part of that conversation. It's not a simple discussion. So the takeaway is our rates don't have anything in them for room and board. They can't. I'm hoping, truly, again, for what it's worth, I'm hoping that we can really navigate into this unlicensed congregate setting environment some way to take the room and board pressure off the providers. That's my hope. But that's just, you know, that's just me. I wish I had an answer to that problem because it's a big one. I don't think they do. I believe they incentivize it because classical independent rehabilitation has no GNA, and we have 11%. And our program support percentage for independent rehabilitation. If you look at the report, there's groups, BRIC groups. Independent rehabilitation is a BRIC group. It's the BRIC that's used for several different services, but the wage may be different. Classical independent rehabilitation has a lower program support and no GNA. We have the program support for independent rehabilitation that came from y'all's ledgers, and we left GNA in. So I think it'll be okay, but
the rates are down. For instance, a person who may receive 10 hours of personal support today, today's rates, the reduction going to your rates is about 25% when you take transportation, which is provided to people in personal supports into the equation. It's actually a reduction.
There's a couple of things that I'm keen to discover specifically about personal supports. But I think this is more related to unlicensed congregate settings than to hourly independent rehabilitation personal supports. I know that because the nature, the definition of what is now going to be supportive living, because that definition was always based on shared hours historically, and as of this moment still is. then providers were free to increase the total hours that they put into that setting only as needed and not necessarily directly linked back to the matrix. So where the matrix rate may be once have been predicated on 5 hours, as time evolved, providers wouldn't necessarily add 5 hours for a new person at that matrix level because they're shared hours. They may have only added 2 or 3.
I'm not speaking of residential, I'm speaking of a person where is unlicensed independent living.
Hour, one-on-one?
Sorry, hourly a day, the hour one.
Yeah.
25%, provide 25% less, provide 10 hours of equal service.
So it's 30 a day now, and it's 25 a day. I mean, now.
Yeah, I've been told that. I've been told that there is a concern about the personal supports hourly independent habilitation. And I do want to see that because it's hard for me to understand why that's a problem if the cost patterns are telling me that the program support percentage is okay, our ERE percentage is higher than what we saw in the ledgers, our GNA percentage is higher than we saw in the ledgers, and our wage is $13. I don't know what part of the rate system is insufficient, but I expect to find out in the phone calls. Bear in mind also, now you're not going to like what I'm about to say, let me warn you. But you're not going to like me. Let me just exit stage left while I can. The rate system is not intended to equate revenues. It's not revenue-based. It's expenditure-based. So if the providers are going to see a huge increase in revenue, not that we want to see that happen. We don't have any reason to want to see that. But we might have missed it because we never regard revenues. We regard expenditures. The whole thing starts with the ledgers. Goes out and gets a BLS wage, adds that to the ledgers, and then we run it against the utilization to see what's going to happen to the budget. We never have looked at revenues. In the general ledger request, I told providers, don't send me your income accounts. I don't want to see them. I don't want to be influenced. To this, right now, I have no idea. I have absolutely, truly no idea who's profitable in Maryland and who's not. I can compare your old revenue to your new revenue for 107 providers, but I don't even know if they're profitable. I don't know. So if it is going to hurt a provider, we need to find which component is causing that. What is doing it? If it's a change in the revenue, that's a different problem. That's a harder problem for me to solve. The hardest problem to solve of them all, utilization problems are not necessarily that difficult to solve. Those kinds of things are fairly easy to structure. I'm not concerned about utilization. That's probably the easiest. The second easiest solution is component percentages. The hardest solution for a provider that's going to get clobbered is wage. Because there's almost nothing you can do about that. I saw that in North Dakota. I'll tell you all this story real briefly. I won't spend too much of your time, but we did rates in North Dakota. In fact, Thomas Cook was sitting in the back as part of that project, as was Mary. There was one provider who was just going to go out of business. And when I sat and talked with them and went through everything with them, it turns out that their average wage for the direct support folks was $20 an hour. This is 3 years ago. The real unfortunate thing is that the chief financial officer for that agency worked for me in Arizona. We were personal friends. She came up to me and she said, "Is there anything you can do?" And I said, "I wish if I could think of it, I certainly would do it. But how do you solve that? If I were to take, Joe might be interested in knowing that $1 an hour in direct support wage translates to $30 million in general fund, more or less. So anytime you add $1 to direct support wage, you are catapulted into big bucks. So I'm hoping that our $13 is higher than the prevailing average, and I think it is. I don't know what the prevailing average is, but I can guess. Yes, ma'am.
Because you're gonna have overtime, and with the DSP shortage, you're gonna have overtime.
Yeah, it's not a component, and the reason it's not a component is because it's not usually coded in existing ledgers. It's usually just part of their costs. It's in their wage and benefits lines. We do look for it though. If I see a general ledger that has contract labor on there, if I see a contract labor line, more often than not, that's overtime, because it leads you into the overtime, because they have to pay that contract labor to work behind someone if they get into that. It's a turnover issue. There is no coding for it. You don't see it as a component because we don't necessarily see it in the general ledgers. But we do talk about it with the providers and the provider calls to make sure that we move money out into ERE if it is overtime related. Did we capture all that dollar amount? Probably not, but we do look for it. Yes, sir.
So there's been a group, a DDA, large group of us that have been working with the VSS providers, the VDA support services, and they're about to change to and be opened up to more providers, that kind of thing. These rates are considerably lower than what have been contracted currently, contract rates. The DDA has $1,200 for the behavior plan versus $559, $150 an hour versus $98 an hour, and new $1,200 for behavioral assessment versus like $700 something. I mean, they're way, way lower than we're currently. These are based on contracts that we have with the state wage rates are in contract. I mean,
what drove them to what they are in the behavioral health system?
What drove them to what they are currently, I think, just negotiations with the DDA, meeting with psychologists, so what standards are, national standards on some of these things. Those were agreed upon rates that the state came up with these agencies for years now. Actually, it's been 4 years of contracts.
On the market field, we try to find a psychologist to write a behavior plan for 12 hours.
So that's when you open up to new providers and start offering these services, but not what we've been paid in the past.
Are we all hearing all of this? The issue is a comparison between the behavioral health rates and the rates that we proposed. I couldn't explain the difference without knowing what went into the behavioral rates, but I don't want to leave your question unanswered. The system is designed to be completely transparent. It's designed to be so transparent that you could answer the questions yourself. So if you had the budgets that drove those mental health rates, you could see what's different by understanding what we've got in ours. Now, again, bear in mind that we got our information from the general ledgers, as best we could understand them. We have also, JVJ, we have a database of probably about 3,000 to 4,000 general ledgers from 10 states over the last 15 years. So we have reasonableness checks that we go to with DDD. Some of the rates initially, when we started working with some of the rates, the first pass at the brick looked low to me because they were low relative to other states. But I can't speak to what's happening in other long-term care groups because I don't know what's driving those. If it's a negotiation thing, I'd have to know what it was based on.
But it's based on a standard for how many hours you should take prostitutes to do a behavior plan and how much per hour psychologists get paid. But
that's what we base ours on. In fact, you can see all of that. If you go to the sheets, you'll see all of those assumptions are laid there. All those, I didn't make any of that. I don't like to base anything on my opinion. We look at the standards. We look to go to the standards. Now, if I miss something, I'm fallible. But we do spend quite a bit of time talking to program folks about what is the standard? You know, what is it that you, our attempt is to base the rates on the expectations that are put on the provider. That's what we try to do. That's why all the components are based on standards. Because we would like to be able to say, we're not asking the providers to do something that we're not willing to pay for. But the only way that I can check whether we captured it accurately or not is to show you what we did. And then hopefully we can work together with finding out where is it wrong. If it's wrong, let's find out where. But we won't necessarily do that by comparing revenues, because we never regarded revenues when we developed it.
Our revenue is very important to us.
Oh, no,
That's all I got. Oh, great. I can look at this now, see what I'm going to get paid now.
you can. You can.
I'm a smart enough to take this and figure out what my payment should be.
Well, there is, yeah, let me speak to that. That is complicated, but it's, gosh, I probably should have said this earlier on tonight, but the rate system, this architecture is actually very simple. It may not look like it is, but it is. Once you see what's going on, it's not rocket science. The brick is the valuation of the hour. What makes that complicated is that converts the valuation of the hour into the rate for the billable unit. And there's a variety of options for that. So like in employment services, employment supports, there's a whole bunch of new ones, which is why you didn't see a budget impact analysis on employment services, because we have no way to compare them. The new stuff is so different than the old.
Like, how do you get approved for an acuity rate, which is higher?
Let me talk about that, because that is what we'll be talking about when we do the phone calls. Where do you fit in that?
I can't figure out my revenue.
Well, because you don't know where you're going to be authorized. Yeah, but you can estimate your revenue by just looking at how many hours you're providing. That's what we're doing. So if you know how many direct support hours you're providing, you can bypass all of that and go straight to the book. That's how we're doing.
Maybe your question is when we do it, I think we're integrated in.
Yeah, okay.
And for example, who dictates the number of hours required staffing supports? And who determines the staffing ratio, the one in for residential, the hours, and the staffing ratio for day program?
Did y'all hear all that? Who decides? And authorizes, yeah. It is designed to be part of the service planning process. Whoever is leading that service planning process, that's where it comes from. But we had to categorize it, like in congregate residential settings, we've set up 3 tiers. So the tiers are an assumption of a range of hours. And the value of that tier is $1 amount, but it is for a range of hours. So if the range is 1 hour to 7 hours and you're providing John 5, you get that tier's rate. If you're providing 3, you get that tier's rate. So the question you need to answer is, what tier are you going to fall in? And that's an authorization issue. But in the meantime, you can get pretty close by looking at how many direct support hours you're providing and multiplying that times the brick, because the tiers are designed to do that. We're going to be normalizing those tiers to the existing staff and supports. We're going to be asking that question ourselves, because we need to know too. I hope you guys really do believe it, because this is absolutely true. Not only do we not want to put providers out of business, we have to demonstrate due diligence to do everything we can to stop that from happening. Medicaid has a requirement that what they call unraveling the network. You can't just launch a rate system and watch the network unravel. They won't let us do that. Now, they know our system. Medicaid is very well aware of the brick method. They've seen it for years, and it's never done that. It always comes with a price tag. In fact, Idaho didn't implement it because the price tag was too high.
Clarity on who decides the number of hours and who authorizes it. So the team process, the person there to look to see how many hours to support somebody will need, and then to make that it's authorized by the DDA.
Y'all heard that? And they're guided by the supports intensity scale and the acute assessment too. Right?
It's based on the healthy screening tool, based on the number of hours left somebody in the 24-hour period, based on the team consensus and sensitivity based on that.
Yeah.
To work on that.
Now, one of the things that we, JDGA, one of the things that we've said, and Chris, I know, has heard me say this, and I think many of y'all have heard me say this or something like it. In the transition from one environment into the next environment, we recommend that the state consider the existing staffing levels to be more likely appropriate than not. That if the providers are doing something, that is more likely appropriate than not. So that we can really predicate how we design this on guaranteeing continuity of care. Another principle of CMS. But we don't know. I mean, I wish I could tell you that I have an absolutely perfect beat on utilization. I don't. We've got a pretty good read on it. 107 providers out of 190. That's more than any state I've ever worked in. New Jersey, which has 800 providers, we predicated the whole system on 60. So we think we're pretty good.
How many of the losers?
I'm sorry?
You don't have the revenue.
We do.
No, you don't have revenue.
Right. I'm not evading the question, but we don't yet know because some of the swings are so outlandish they can't be right. Like I've seen some of them whose difference is 1,000%. Something's wrong. So those are the ones that are going to say, call us next week. I mean, we're going to get to those as soon as we can.
The rate has the day program rated to 1-to-1 or 1-to-4 staffing. Is the maximum staffing ratio now allowed when we 1-to-4?
Is it?
Yeah, so we're looking at, is that the 1-to-4 ratio that we're looking at will be starting in July of, we'll have a transition year. We'll have stabilization services right now being paid by the day. Once we transition into the fiscal year 20, which is calendar year 19, we'll move into the hourly rate. And so we're looking at the 1-to-4, also because we're looking at the community, making sure we're making sure that we still have smaller ratios so that we go out and engage in the community. So as long as we have, right now, the way we have our regulations done is a daily rate for those services. We have to continue that, and then we'll have a transition year, and we'll be implementing the hourly to the 1-to-4 ratio July of 19.
The only concern I have about that is I can't find enough staff now. And I've got lots of individuals that are 1-to-8, 1-to-10, 1-to-12, 1-to-20, and I now got to find the next, 30 or 40 staff.
So in those rates right now, what we're talking about in the rate study will not only be implemented for the day programs because we still have that daily rate.
Right, but even 2024, 3 years from now,
You're going to be able to solve that problem.
my staffing issue is not getting better.
Yeah.
So I mean, it's a very strong concern that you're going to box us into a ratio that's not necessarily necessary for all these businesses, but it's going to require us to do that just to get the rate. And I don't necessarily need that level of supervision for some of the businesses. For some of them, it's too much. I understand the outer part of the
Up to 1-to-4, so that is what it has to be a 1-to-4 in the rate of 1-to-4.
Yeah, the 1-to-1 and 1-to-4.
That's the math.
I just want you guys to think about the impact of the additional staff that we're going to have, even with the number of individuals we have right now, and increase everybody to 1-to-4 ratio. I need to increase my staff by probably 25%. I can't find them now. I've got 15 vacancies out of 110 right this minute. I don't have an answer. I don't either. There's not. I mean, unless we get to the point where we'll take $15 an hour and we're able to go out. I can track that at $15 an hour. I can't track them $11 an hour.
It's also important for your supervision. They come
There's one other pressure that I want to make sure I mention tonight. The IT development process is moving forward, and they have to have certainty in some of their data sets to be able to finish their work. So some of these issues about like the ranges, where does the rate come from that's within the range, that we're hoping to learn by talking to providers about where it's, I talked about the 3 tiers, what the rate is for each tier. I'm hoping to land on that by talking to the providers of where's the best fit. It doesn't have to be a straight average of those hours. It can be leaning in one direction or the other. And I'm hoping to be able to manipulate that to fit the provider's experience right now. But we may not have the luxury of waiting very long to have those answers for the IT fix. So I may scoot that part of the discussions towards the front so that I can resolve those tier issues as soon as possible, unless we can get a placeholder. If we can get a placeholder, then we've bought a little bit of time. But I don't know whether we're going to be able to. So there's all kinds of pressures coming into things. We don't, 6 months to do the cost sounds like a long time. A year and a half sounds like a long time, but it's not. Yes, ma'am.
What about target case management?
Yes, targeted case management. The biggest change in targeted case management is a shift away from conceptualizing targeted case management in terms of capacity. The targeted case management, when I started working on this, it was over 60% capacity, and the very first thing I did was change the vernacular to let's not talk about capacity, because it's not a capacity issue. It's really a capture issue. Are you able to capture all of the billing hours that you really should be able to bill for? So if we can talk about whether or not targeted case management is effectively billing or could be more effective in billing, your revenues would go up. So let's shift the discussion to caseload. Because most folks, I've told y'all, I've done targeted case management rates in about 4 or 5 states. It's always a caseload issue. Where do you want to be with your caseload? Issues like, do you want to have a single caseload assumption, 1 to 40, 1 to 50, 1 to 30, whatever it is, or do you want to bifurcate? We talked about how it's usually not a good idea to do 2 different case management ratio sets, because then you put people into groups that may be artificial. We were directed by the states. The state said we would like to look at a 1 to 35 ratio. Was it 1 to 30? It was 1 to 35. It's 1 to 40 because I couldn't. It's one of those interim steps. We still want to move to 1 to 35. We just can't get there right now, because even at 1 to 40, we're at I think it's 15% above. I haven't seen the case management percentage increment. I know ours is higher, but I don't know how much. But we're not recommending that the ratio is 1 to 40. We're not saying that's a good caseload. We're saying it's an interim caseload. We want to move to 1 to 35. That's the state's objective. We're also, the value of the case management, the annual value is I believe where it should be. It's about $120,000 a year. So we really need to make sure that we increase the efficiency of billing for target case management. I think that's where the solution is, among other things. We also, one of the changes that we made to the analysis of target case management, which is another example of the state taking the position, let's do the right thing, whatever that is. And that is treating the time between the time a person comes on the job and a time that you can bill for them, treating that time as though it were training, as though it were a training expenditure. So we were able to build into our rate an assumption of that percentage instead of just the dollars that you use for training. Most states wouldn't do that. Most states would say, are you seeing it in the ledgers? No, I'm not. But it was talking to the targeted case management people that made me aware of how big a problem that is for them. So targeted case management, I think it's one of the better rates that we've done in this system, but it's not a 1 to 35. We would like to get it there. I can't tell whether y'all are okay or you just don't want to tell me that you're not.
Getting back to the overtime question that I had, I guess I have a hard time understanding how if this is a rate structure that we're really trying to demonstrate what the true cost is and leave out critical components, especially tied to a wage.
They're not left out. They're not left out. They're just, it's not articulated as overtime, but they're not left out.
But if you're using a standardized rate, you're not using a rate of premium.
Oh, we're not expressing a different wage. No, we're not. In fact, and I'll tell you why. There was pressure on me to, rather than blend the DSP tiers, because we've got the advancement tiers, which represent an increased wage, to create a rate for each one of those, so that you'd have a rate with a wage level of $12, a rate with a wage level of $13.50, and one with a wage level of $18. That's what everybody wanted. I mean, even the state was considering that, and I said, no, you don't want that, because for every option of the rates, you'd have 3. So I calculated, I think initially 60 rates we'd need for residential just to accommodate that. Who's going to know what to offer us? So a lot of times you'll see in the rate system as it becomes clearer and as you become more familiar with it, that there's a lot of parts to the rate system that are left up to the provider to maneuver. And what we've tried to do is make sure that we've got enough in there so you can maneuver, that you've got enough room to maneuver. One of them is the tiers, is averaging the hours within those tiers. We're not saying that if the tier's 1 to 7 and you do 2, you're going to be punished, because anything within the 1 to 7 tier is fair game. That's what's being offered. So we're allowing the providers to maneuver within the tiers as you see fit. There's a lot of places in the rate system where that kind of variability is left intact. Like one of the things that I need to do, and I need you guys to tell me how you think this would be best. How can I do this the best? I need to be able to communicate to your employees that the wage that is in the rate system is an average wage, not a starting wage, because they're going to see that too. They're going to see this too, and they're going to come to you and say, I'm not getting $13 an hour. They need to hear it from me. They need to hear me say, that's an average wage. It's not a starting wage. If it's too low, too high, it may be, but it's not a starting wage. The other thing that I've heard before, and y'all haven't asked me a question about this, but I'll go ahead and answer it. Why didn't we peg the wage to minimum wage? A lot of the providers prefer to use a buffer. Anything, whatever minimum wage is, our wage is going to be 35% higher than that. This doesn't matter, but I never even heard of that until I came to Maryland. The reason we didn't do it that way, and I do understand the reason why you do it, why y'all have done it. That's been explained to me. But the reason we don't do it is because we know what the standards are. You can go and say, this is the job description we think best fits our standards, and we can go get a wage for that. And in our report, if you look at the wage, the BLS sheet, at the top row, those are the BLS reference numbers. So you can go to bls.gov and go to the state wage levels and research that number, and it'll give you the job description that we predicated that service on. But that is also another example of the averaging, where we tell the providers, however you want to work it. Whether it's high enough, separate question. We'd all like it for it to be higher. I did run the numbers at $15, by the way, and it was $70 million, general fund, just for that.
I guess the fact of the matter is, for the overtime question, practically speaking, with overtime, most staff right now are getting paid $15 an hour.
What I would strongly recommend,
Yeah.
if I were you guys, I would start coding your ledger with an overtime line. Some of you did, some of you didn't. Most of you did.
If the break itself is predicated on the BLS thing, and I'm multiplying the break times the number of hours, but the overtime percentage is not in ERA, is it?
If we knew it, it is.
But if it's not, you're left with where in the provider?
In the direct support line. Wherever it was, because we wouldn't know where it is.
So it's in there, it says which category you have it.
Yes.
But it's in your percent. I think that's the concern that I'm hearing, and it's not, when you think about the brick being the BLS wage, my first thought is that there's no overtime built in. But the additional percentage is built into the other components.
But the BLS wage does include overtime for that job category.
At 13 an hour.
Well, the BLS wage is not 13 an hour. That's accelerated using the CPI.
Okay.
But if you go into BLS, you can see what's in there. We didn't, those wage levels came straight from BLS. The way the BLS data is compiled is they take a job description and they have a whole array of ways that they peg that wage for that job description. They get criticized for that, actually, because if you fall within a certain range, then you'll be either in one category or another. So there have been some people that say the BLS wage level expressions are artificially low because of the way they categorize those things. But it's not based on this is a regular hour and this is an overtime hour. It's based on the cost of that job description for all the data that they receive for that state, for that job description. It's a bigger average than you might think.
The BLS rate has the overtime component built into it as well.
Yes, it has a bunch of things built into it.
And I'll use a round number for a second. If it was a $15 BLS wage and it had 10% of overtime built into it, the BLS base wage is actually $13.50 plus the variables and whatever else you've got to get to 15.
That's right. But the problem is that overtime expenditures themselves are influenced, very strongly influenced by things the BLS is not going to see. Like if you're in a rural area and you can't find staff because you don't have a lot of staff to hire, you're going to have a higher overtime percentage than someone else in the same state. So the BLS capture of overtime is not necessarily going to work for you. That's why I'm saying if you really want to solve that problem, start coding your ledgers. For those of you who don't, code your ledgers with overtime, because we always do recommend that the state at some point in time rebase the system. Now, when you hear me or anyone else use the word rebase, we mean change the percentages or the wage, but primarily the percentages. Go in there and update those percentages. The extent to which they can rebase the system accurately is going to be directly related to the extent that you can tell them what those expenditures are. That's why we offer to do the workshops to help you do that, for those of you who don't code the overtime. Yes, ma'am.
Just maybe a little bit of every time it's still talking about hours. If the person includes training, is it just the cost of the training, or does it also include number of unbillable hours to train?
It includes the hours. In fact, if you go to the final report, there's a schedule that shows the training calculations and it shows the hour assumptions for each service. And
on the increased requirements?
Yeah, those all came straight from the state's requirements. And I think there's three different ones, depending on the service. Let me kind of give you we've got about 15 minutes left, and I just want to get.
Not only look at the required things, but the amount of that position.
Yep.
To do that, so that we guys cover that. So I think that's something that a lot of us know how that came about. So it doesn't just talk about the required training, but how do we state the coach you, or I coach you in 2-3 months to hire somebody, and that was pretty.
That's a targeted case management issue. But even in the other services, we did both types of training, which is beyond the ledgers. And to give you an idea, when you look at the training matrix, you'll see that the percentages are, I think, 6.5%, 8.5%, and 11%. The ledgers were down around 1.5%. So the training percentages are significantly higher than the ledgers. Every time that I deviated from the ledgers, I had to have a defense for it. Because remember, go back to the primary CMS principle that it's cost-based. So CMS, like you hear me sometimes talk about unfunded mandates. Very difficult to get into a standard fee system because there's no history of it. So when we go into an unfunded mandate discussion with CMS, we really have to have our ducks in a row.
I was going to keep track of all the training hours, whether it's training one-on-one with, these staff as a new consumer, or whether it's, require BPS or different things.
Yeah.
So all of the hours for training and direct care in one line under salaries, and the number of hours provided isn't actual billable hours.
Right.
So I didn't know if that variable.
We tried to capture that. The worst example of an unfunded mandate situation that I've experienced was in North Dakota. While we were doing the rates, the workers' comp doubled. No history, but we knew that it doubled. So we had to build our ERE percentage to accommodate the new workers' comp, even though it had never been used. When we were in New Jersey, the same thing, I thought the same thing was going to happen with the ACA, but that was going to drive the ERE percentages off the map. So I put together a group of providers to help me figure out what is that going to be. And it turned out not to be, we didn't even do it. We didn't need to do it. So we try to accommodate unfunded mandates, but they're difficult to do because they do deviate from the general ledgers. So to recap, in the coming months, we're going to send out the information that we have from you that will include what we think is going to happen to you compared to your revenue. That's the only revenue look that we're going to be doing, is here's the brick method and here's what we think is your past revenue. If y'all haven't sent us any DCS hours, please get that ready because we'll need to do that. You'll want to do that anyway. Basically, we're going to be doing what you will want to do. What is this rate system going to do to us? So if you can help us, we will help you answer that question so we can answer it together, because if there's a problem, we'll look at it. If we have gone off the mark somewhere, then I'm willing to admit it and do what I can to solve it.
So we try to catch the hour data. We did that on a worksheet that you gave us.
Yes.
Last fall. Do you want to see if we can post that on the state's website?
To do what?
Post that worksheet on the state website for providers to be able to look at that, fill that out, and have it easy for your conversation.
I don't think, the question is, y'all remember the DCS worksheet that we sent out? The question is, do you want to put that up on the website? Oh, yeah, that might be a good idea. Maybe just put that. Yeah, just put that form out there. Yeah, that might be a good idea. We're missing a fair amount. We have 107 providers is a lot. That's you might think it's not because there's 190 providers in the universe, but 107 of 190 is pretty dang good. We're not used to having that much. The response from the state of Maryland has been very good. The providers have been very forthcoming. They all have been very helpful. And I think you've been very reasonable. There's a lot of times where I feel there's a lot more anger
This lady.
Yeah. That's in the future, something to look forward to. But we are very sincere in our belief that there isn't a problem. If there is a problem, we can solve it working together. If we can't work together, we won't be able to solve it. So we really do believe that. And like I said earlier, please don't call us because you'll overwhelm us. But if you send us an email because you have a question, just put question in the subject line, and Claudia will triage that to me pretty much within 24 hours. And then again, you'll see me again at the second half of March. We'll do another round of this stuff. Did everybody get your questions answered? Everybody got your questions answered? Did you? I'm not sure. Probably in the next, you mean for the schedule? Probably in the next 2 weeks. We wanted to make sure that the state was okay with us using their website for that. And they said they were okay with that today. So,
when should we anticipate an email from you?
The 107 emails will go out. I'm here all week. And then Claudia and I are going to start sending them out a week from today. So providers will start getting emails from us next week. Thank you, everybody.
If you received your card,